Hey everyone, and welcome to Chef AJ Live. I'm your host, Chef AJ, and this is where I introduce you to amazing people like you who are doing great things in the world that I think you should know about. Well, as often happens with this show, most guests are referred by previous guests, and today's guest was told to me, I can't speak English on show number 2. I learned about today's guest from a regular on the show, Dr. Doug Lisle, who is a very passionate advocate about the use of antidepressants in this country and is always promoting the book of Robert Whitaker, Anatomy of an Epidemic. And Robert Whitaker actually was a guest on the show, and I can link to that below. Well, Dr. Lisle knows of this psychiatrist who practices in the Los Angeles area named Stuart Shipko, because he is pretty much the only guy that helps people get off these drugs. For many people can't get off or have a very hard time getting off. And we're going to learn more today about the dark side of antidepressants. Please welcome Dr. Shipko. It's nice to meet you, and thank you for your pioneering work.
You're very welcome.
Yeah. So how does one get into this field of getting people off drugs when, as we mentioned before the show, most of psychiatry is about putting people on drugs?
Oh, it all started in the 90s. Well, first of all, when Prozac came out in 1987, it was obvious that there were a lot of side effects. I could see that this was not the trouble-free drug that they were talking about. I didn't even put people on it for a long time. I just had patients come in who were already on it. Now, so part of it has to do with age perspective. But when I trained, we had antidepressants, and you took people off of them. The argument was never to keep them on indefinitely. The argument was, how long after they're better should we take them off? A month? 3 months? So standard practice, best practice, was after somebody improved to take them off the antidepressants. So when Prozac came out, people would show up in the office. They had another doctor across town. They wanted somebody new. They were feeling perfectly fine on their Prozac and other drugs. And it was time to take them off of them because they were better, but it didn't work very well. Many of the people had already tried to go off of the drugs, and when they tried, they got really sick. So when I suggested it, they didn't want to. And others, I watched them get really ill as I took them off the drugs myself. We didn't know much about tapering, but I could see there were problems with it. Now, in the early 90s, I had one of the first websites on anxiety. I was a pioneer on the internet. And I wrote about something. I wrote about a couple of things. One was that people who had panic disorders often had the worst panic attacks of their lives after they were given these SSRIs, Prozac, Paxil, Zoloft in those days. Just on an observational, I had no idea that when they did the clinical trials, the people were also put on benzodiazepines because otherwise they had panic attacks. But I just wrote about that side effect. And I wrote about one other one that's the first doctor to have written about what they now call PSSD, post-SSRI sexual dysfunction. I wrote about the fact that patients were complaining of persistent dysfunction after stopping their medications. Those were really the only two things I wrote about. I also wrote about people having a hard time getting off of them. Well, so I said that. So this was amazing what happened after that. Doctors all over the country were saying these drugs were safe, effective, had no side effects, and weren't addicting. And people could not find a doctor who would acknowledge their side effects, their inability to stop the medicines. And literally hundreds of people from all over the country came to the office to tell me about their side effects, even though I didn't know what to do about them. They were desperate to have a doctor who could acknowledge that they had side effects. And it's very simple. If you didn't have it before the drug, and after the drug you have it, it's a side effect. Or at least that's the way things were a few decades ago. Nowadays, if you have a side effect from the drug, they tell you you have new bipolar disorder. That's only half of a joke, because I think that's what happened. So that was the beginning of it. That was the beginning of so many people coming with so many different types of problems. And that was the point at which I began to feel that people shouldn't start these, particularly without proper informed consent. And then also, I wanted to keep people from having these problems. And if they were feeling well, to ask them if they wanted to go off the drugs and then try to stop them. So that's how I got into it. That's where it all started. It snowballed because people still can't find doctors willing to acknowledge drug side effects. And I think the standard of care is never to take anybody off one of these drugs once you start them. Now, I want to mention that depression, when I trained, which was before everybody was born, but depression was a condition that was time limited. I think Dr. Bob Whitaker mentioned this too, but depression is a time limited condition that gets better on its own, usually without treatment. And that was the description of the condition. And then after the SSRIs came out, the description changed and they said these are chronic relapsing conditions. And how can the description of the condition change? Well, the answer was the drugs were making them chronic relapsing conditions. So I mean, there's a lot behind it, but I just think observation, listening to my patients, having common sense guided me in the direction I went into.
Are there any other doctors like you?
You know, there are. They don't advertise it because it's not like a winning thing, but I run across them. I run across psychologists mostly, but sometimes there are other physicians who are variously interested in this. Increasingly, psychiatrists are kind of conceding that these drugs have more symptoms, but I do find other doctors around the country. And then there's people, you know, there's people who, well, you know, I think the people who write about this are not the same as the people who actually are in the trenches to some extent. But you find some guy somewhere where you wouldn't expect it, who are taking people off of drugs or giving them good informed consent before they even start them.
You know, the fact that it's so difficult for people to get off them, what is it about that? Are they addictive?
Well, it depends on your definition of the word addiction. A lot of times people say they're not addictive because people don't crave higher and higher doses like they do with, say, heroin or sometimes benzodiazepines. I disagree with that. It's not an immediate thing, but yeah, you need higher and higher doses as time goes on. If the definition of addiction is that you can't stop something even though you want to, yes, they're addictive. What percentage of the people can't stop it? There's been very little studies on it. The best one came out of Italy a year or two ago. Half the people in their study were able to go off of the drugs. Yeah, well, the other half, so half of them were able to just go off. The other half of those had severe withdrawal effects. And of those, they didn't say exactly how many couldn't go off because they kept trying. But so you got to figure easily a quarter of the people who go on these drugs can't stop them. You know, I got to make it a little bit more complicated because sometimes people can't stop these drugs after a low dose they've only taken for a month. And other people, after 20 years, just kind of quit it and there's no problems. So there must be some sort of variable susceptibility to this. And then also, to make it even more complicated, I'm not sure that what role the emotions play in being able to stop it. And I'll tell you why. So I had a gentleman come into my office. He had been on one of the SSRIs for 3 years. His psychiatrist died, and he wanted me to assume care. And I said, well, you've been okay for a long time, right? Yeah. Okay. So let's taper you off of it. And there's no real medical reason why you have to stay on it. So we developed a very slow, reasonable tapering protocol. And as he got down to the lower doses, he wasn't even so low. He couldn't stop it. The withdrawal was just too intense and too uncomfortable. So this person was an actor, and he continued the drug. A year later, he got a role. It was a big role. The production lasted 17 hours a day. He forgot his medicines. And 2 weeks later, he says, oh, I forgot my medicines. And he didn't have any withdrawal or any problems at all. So he didn't even taper. He went off at cold turkey. He knew from talking to me before that there was a risk of developing additional symptoms like 3 to 6 months after stopping. So he waited till he was off the drug for about 9 months and had no problems to tell me, well, okay, I'm off it, and it's completely done. So there must have been something about being so busy that made the withdrawal easier. But I'm just saying it's complicated. Who can stop? Who can't stop? And why is that?
Yeah. You know, Chris, who's watching live, mentioned that there's a new study in London that shows it's not a lack of serotonin that causes depression. Isn't the whole system flawed about why we need the, I mean, you know, that's their theory that we need, you know, when you, at least when you see television commercials, you know?
Yeah, there was never any proof that low serotonin caused depression. I know the study that they just did, I think that was Dr. Moncrief, where they looked at everything they could find about serotonin, and they were unable to show that low serotonin caused depression, but they knew that before. There were studies where they depleted people of serotonin. You do that by giving them a diet with no tryptophan in it, and it didn't cause depression. And then they also looked at cerebrospinal fluid metabolites of serotonin, and they weren't low in people who had depression. So that's, I mean, I'm glad that they showed it in writing and documented it, but they never thought that this was the cause of depression.
Yeah. For the people that experience withdrawal side effects, what are the most common ones?
Okay. There is a set of symptoms that people feel as they're going off the drug, which will be, anxiety and depression, irritability, electric shock sensations around the scalp, which are commonly referred to as SAPs, flu-like symptoms, vertigo related to the eyes. So when they move their eyes across the room spins and they fall on the floor. So there's a bunch of symptoms besides that, but those are, I think, the most common, just ones as you're going off of it. Now, one of my findings, which has taken me years before I really realized this was the case, is that 3 to 6, they can go all the way off the drugs. They can have all of their withdrawal symptoms, the initial ones gone. And then 3 to 6 months later, they can develop akathisia.
Yeah, what is that? I've heard that word, so please.
I'm going to spell it. It's akathisia. It's an unbearable sense of restlessness. It's an urge to move, but movement doesn't help that urge. It also, and it's that's a movement disorder, well described from antipsychotics, and you get the same kind of a thing with the antidepressant withdrawal, but it's a little different because they may not have the movement part of it, but it's a level of anxiety and depression so intense, nothing matches it. I've never seen anything like that with patients, even hospitalized patients. And in my experience, and I use this as a diagnostic tool, they all are considering suicide. They don't want to die, but they're thinking, if this is going to last, I always have the option of killing myself. So that comes up fairly abruptly. It's usually around 3 to 6 months if it's going to happen. I don't know what percentage of the time that happens, but I consider that to be more serious than the usual withdrawal symptoms. Now, akathisia can also happen during the early parts of withdrawal as well.
To me, suicide is not an acceptable side effect of any drug.
Well, now suicide is a side effect of the antidepressants. That's a different thing. This is a discomfort so intense that people are all keeping suicide open as an option, but they don't want to die. Let me talk for a minute about the suicide side effect. Suicide can emerge out of the akathisia, and akathisia can happen anytime during treatment. But I'll tell you what I've seen that's kind of different. You know, they talk about, oh, well, the antidepressant activates them, so now they can act on their thoughts. That's an old classic theory of antidepressants. But what I was seeing in my practice was people who developed an obsession with suicide, but not like, oh, I want to end it all, but as if, oh, what a nice, wonderful relief this would be. And, you know, it'd be great for my husband and children too. The reason why I heard about this more than other doctors was I would warn them about the potential for suicide before I prescribed the drugs. And I would tell them, if that happens, if you feel anything like that, just stop taking the drugs and tell me about it next time. I also had people who came into the office because they were suicidal from the drugs. It's a preoccupation. It's really different from wanting to end it all. It's this preoccupation. Like one woman said, I'm looking through your window there. I could jump out in the street in front of a car. I see your light socket there. I could rip it off and put my finger in it. She's saying that her mind is going like that all day long. And it was a curiosity to her. So there seems to be something really special. I know there's lots of drugs that are implicated in suicide, but I feel there's something special about the drugs, like they act on the suicide center of the brain or something.
Yeah, that's really scary. Are you unequivocally against the use of SSRIs in all patients?
No, I'm not. I'm unequivocally against the use of these SSRIs in any patient without informed consent.
And what is informed consent?
Informed consent, okay. I mean, there's a lot. Informed consent itself means that you warn somebody of the potential risks as well as benefits of the treatment. And you're also supposed to tell them about alternative treatments that exist. But let's just talk about the risks. I usually start off with suicide. It can make you want to kill yourself. But then I tell them, if you feel that happening, don't take another pill, you should be okay. The other thing is malignant weight gain, which is important to everybody. But you may gain, even if people are seemingly eating the same diet, they can gain a lot of weight. I had one patient, this is Los Angeles. So I had one patient who hired a chef to make all of her meals and put them in a box outside her door 3 times a day. And she got a personal trainer and worked out very hard. And she gained like 10 pounds a month. She was a little gal too, 10 pounds a month. 6 months later, she was 60 pounds heavier. She stopped the medicine and kept exercising and dieting and still couldn't lose weight. That's kind of an extreme story, but the weight gain can be very difficult to take off. Then I tell them, you may not be able, despite these potential problems, you may not be able to stop this when you want to. So the suicide, the weight gain, not being able to stop it. I forget what other things, there's so many of them. It is like, early ones, gastrological problems, that it may make you, may interfere with your thinking ability. It may make you, and of course the section, you may permanently lose your ability to have an erection or to get it sexually aroused. So those are the things I tell people. And I wrote a little ebook sort of outlining that, also outlining the difficulties of stopping these drugs that can happen. And once you do that, almost nobody is going to go for these drugs. But if I give somebody those warnings and they say to me, I understand what you're saying, and I warn them about akathisia too, which is something so uncomfortable you can't imagine it. But if I warn them about all these things and they say, oh, doctor, I'm suffering, I really need something, we have to try something, I might do that. But I have something I try first, which is SAMe. You noticed in that talk with Dr. Whitaker, he pointed out that these drugs really are barely any better than placebo. After they can get a statistical significance because they have huge sample size. So it's, just a little bit over, 50% of the people get better with placebo, and another, 51 or 52% get better with the drug, but it's statistically different. So they say, okay, the drug works. Really, the conclusion you draw from that is that placebo is the preferred treatment. You're going to get about the same results with no side effects or minimal side effects. Placebo has side effects. So getting back to SAMe, it has been extensively studied, and it has been found to be as effective as imipramine, which is often considered the gold standard in psychiatry. Of course, imipramine helps 50% of the people. It was barely better than placebo in the original studies. But nevertheless, they showed it was equivalent to imipramine, and it's manufactured in Europe, in Italy. And in Italy, it's a very widely used antidepressant. Then, to boost, it's a methylating agent, which means it will, an amino acid plus a methyl group becomes a neurotransmitter. So it's thought that it freshens up and excites, makes you more robust in your neurotransmitters. And to facilitate that, a little bit of vitamin B complex will make the reactions go better. Well, I also, by telling them there's these studies, it shows just as effective. And also by enhancing placebo with my talk, and also the B complex turns your urine yellow. So placebo is better if you have more pills than one pill, and it's better if you have something else like turning your urine yellow. Wow, I feel it must be working. I'm giving away my secrets. I'll never be able to do this again. But, I will have to say with SAMe and B complex, my results were as good as with antidepressants. And the patients can look it up online and see the efficacy. But I will also say, if after that doesn't work, I also will try, I give them exercise programs. I don't just say go out and exercise. I tell them exactly what I want them to do based on what they're interested in. And so exercise is a very effective antidepressant. But if those things fail and the person says that we really have to try something, this is miserable, I will prescribe one.
Wow. Which one? I'm curious. Do you have a favorite?
No, they all have. Everybody will know somebody who had something and they want the same thing.
Yeah.
I'll tell you what I don't do. I don't do this. Well, we'll keep trying until we find the right drug for you. Yeah. That, I'll try one, maybe two. And after that, I say, it doesn't look like these drugs are working for you. But the standard of care is for the psychiatrist to say, well, the first drug may not work, but we'll just keep going until we find one that helps you. Well, the problem with that is each new drug has side effects when you start it. And then there's side effects when you withdraw the old drug. And in that process, 3, 4 drugs down the road, you don't know where you are. What are you? Are these side effects? Are these initiation effects? What are you doing? So I generally will bow out and say, I try and argue for psychotherapy or whatever. But if they want to continue to search drugs, they can do that. I do not find that the so-called genetic tests really are meaningful. They aren't going to tell you which drug is going to work or not. They're going to tell you how they're metabolized. The relationship between metabolism and how well they work isn't well worked out. So I won't say, drugs are neither good nor bad. When they're used appropriately. There are people who sometimes are so desperate and their life is going nowhere. And an antidepressant makes a big difference. I'll tell you a story about a patient where it made a big difference. One of the groups of people I think that it might be best for are people who are abused when they're very young. And they don't have verbal access to the memories so that they can work it out so well. Such people often, they get very upset easily. They ruin their relationships. They scream at people. They can't seem to modulate it. And the antidepressants work by making them, everybody makes them less reactive to their own thoughts and emotions. And I had one woman, she went through all, the informed consent and tried other things, and none of it worked. And she said, we got to do something. I ruin every job. I ruin every relationship. My parents hate me. Everybody hates me. And the Prozac I gave her made all the difference in the world. She was able to establish a wonderful, loving relationship that endured for years. She became promoted. The manager held her jobs. But, when I did give her informed consent, I told her, it's a little bit like Cinderella's carriage. Eventually, it's going to turn into a pumpkin. And I said, we're going to keep you on low doses because you'll need more and more over time. So she left Los Angeles after a few years. And I kept her on low doses. But, around 8-10 years later, she called me and said, well, you're right. I reached the maximum dose of Prozac and it's not working anymore and nobody knows what to do. So I'll pose a question to you. What would you do in a situation like that? I gave her 10 good years, 10 of her best years. I don't know, maybe they did find something for her, right? But I don't think, it's a puzzle. Should you do it or should you not do it? It's not going to last. What would you do?
I don't know. I would do lifestyle. I would send her to the True North Health Center and put her on a healthy diet and fasting and exercise, because you had mentioned about exercise, and I've often heard that exercise is the most underutilized antidepressant and anti-anxiety medicine, but I'm wondering, are these people really doing it vigorously every day?
Well, no, the ones that don't do it, don't do it. But I've had some fabulous success. I've had fabulous success with exercise where I'm not a personal trainer, but I really enjoy working out and know a lot about it. So I would put them on programs of cardio and weight training. And when they come in for the visits, I review how much they're doing. If they don't like something, you got to make it something they like or they're not going to do it. But if, so I find out what they're doing and how it's going. And I've had some people where no medicines, serious problems, but the exercise alone helped it. Or of course, using the old model, if you don't give them drugs, they get better anyway, right? But exercise is, for the people who will do it, is very effective. But just like diet, you can't tell somebody do this and they do it. They do parts of it, or the person has to be really into it and motivated. But I can't say enough good stuff about exercise and body image. You get those big muscles or slim down. That feeds on it.
Before we went live, we talked a little bit about Ann Wigmore, because I had listened to a podcast with you where it sounded like you knew her. And I'm wondering, do you think that healthy eating could help some people with some of their problems? Because I know that when I see people that eat a lot of sugar, drink a lot of alcohol, they often have other problems in addition to health problems.
Absolutely. I'm not an expert on diet. But yes, I think that, well, for starters, eating at regular intervals, and then also, as you know, largely plant-based is better, and also low glycemic index is better. So I will advise people on diet. I will say this: people are very sensitive about it. If they come in for you as a psychiatrist and you start talking about diet, many people get really turned off. I'll tell you something else I found: marijuana. There's a lot of people who are depressed because they're smoking pot all day long, and they don't realize they sunk into it. They don't even have to quit; they just have to cut back. But that's an increasingly important aspect of lifestyle. But diet is important. Let's get back to Ann Wigmore. So Ann Wigmore is a woman who was talking about a completely natural diet. She herself, in her memoir, writes about how she had bad arthritis and she was crippled, and then she went on a diet of completely natural foods. We're not even talking non-processed. She doesn't even do store-bought stuff. She makes all her own food. So I became friends with her because she was in this brownstone apartment that I lived in Boston. And in her apartment, she had cases and cases of sprouts. She grew her own food from sprouts in her apartment. And then from there, she also made fermented for proteins. She made fermented dishes, but there was not a pesticide. These are totally natural foods. Her apartment was also a mess of fruit flies. But she worked with totally natural food. And I told you earlier, I've had an interest in healing, whatever healing is, what is it? And Ann Wigmore was one of the people who was an internationally known healer. And she introduced me to 3 of her people. They're not patients, they're peers of sorts. She introduced me to 3 of her followers who were cured of metastatic cancer. So I met them personally, and they told me that one of them had malignant melanoma, which is really when it's metastatic, that's a death sentence. And of course, that was like 30, 40 years ago, and the treatments weren't even nearly as good. And one of the patients that was cured was a hospital administrator of one of the big hospitals in Boston. I interviewed lots of other healers or people who had healing abilities. Nobody ever introduced me to somebody who was cured on that level. But Ann was a funny little lady. I mean, she was, I'm short, she's tiny, and she's real energetic. And she had a spirit that was healing too. I remember I spent a lot of time over in her apartment talking to people, and they had groups, meditations. It was kind of nice. But I remember this one woman was anguished. I mean, her face was so anxious. She says, "Oh, they'd call her Dr. Ann because she was a doctor of divinity. Dr. Ann, what should I do? And she looked up at her and touched her face. And she said, have a glass of Rejuvelac. Rejuvelac was a drink they made from sprouted wheat.
I know. I used to have that at the Optimum Health Institute. It doesn't taste very good.
Well, let me tell you, just the touching her face calmed her down. It was so beautiful to watch. And then she had her glass of Rejuvelac and she was okay the rest of the day. So, and in my belief, I mean, she had a good product, totally natural food, but I think she also had a healing spirit. She was a fabulous person.
That is so cool. Two guests in 1 week who knew her. Dr. Shipko, how do you get people off these drugs? Do they have to come into Los Angeles to see you? Can you work with people virtually?
I can work with people virtually. I'm only licensed in California, but you know, the principles are very simple. And first of all, I want to just say, a lot of people can just go off these drugs. A lot of people just stop them and they never think about it and they're done. But by the time somebody contacts me, they've usually already failed. If they haven't failed and they just want to know how to go off of it, they already have doctors, they already have prescribers. And I tell them, you know, basically, my basic strategy is 10% cuts per month, as long as it's reasonably comfortable. And then when you get down to the last 20%, 5% cuts. There are more precise ways to taper, but that's generally what I advise people. If the tapering process is so difficult early on, if you can't do 10% from whatever you're on to begin with, it's probably not going to work. So I give them that advice. Sometimes I talk to their doctors if they want me to. I tell them to take it back to their doctor. That way I talk to people all over the world with these sort of issues. So that's the first step. Now, if they're on, I don't really work with people who are on 3 and 4 drugs at a time. I prefer people only on 1 drug. A lot of times people are on a benzodiazepine and an SSRI. If that's the case, I tell them to go off of the SSRI first and wait a few months after that before attempting the benzodiazepine. The reason being is that SSRIs ameliorate withdrawal symptoms. I mean, benzodiazepines ameliorate withdrawal symptoms from the SSRIs. So it makes the tapering easier. But now Horowitz out of England shows that the receptor saturation is such that you need to do what they call parabolic tapering. The straight cuts of 10% are not what he recommends. He recommends, like, if you start at 100, take off 10%. Then when the next one, you're at 90 milligrams, you take 10% of that. And so you only drop 9 milligrams and so on. And then when you get down to the lower levels, you know, you're approaching infinity in your cuts. I agree that it's good to go slower toward the end. I haven't been doing parabolic tapering, so I'm not sure whether that's actually a better strategy. There's also another way to go off of these drugs that seems to be pretty good. They have what they call tapering strips. They're out of Amsterdam. Anybody can get them. You can buy them as long as your doctor sends them a prescription, they'll send you a tapering strip. They have the pills weighed out in ever decreasing quantities, and they go fairly slowly. They have two levels. You can ask for a fast taper, slow taper, and they've done studies. I have some questions about the studies, but you know, it looks pretty good. It looks like the tapering strips seem to be a useful way to go off of them. They do have a percentages of people who still seem to be not be able to go off of it. It's sort of buried in their data. But I think that those tapering strips are really good. And it also helps from the standpoint of a lot of times the pills are not made in the dosages you need. So there's a couple of ways of, so like The classic drug that people find hard to get off of is Paxil, and they make it in certain increments. So if you want to cut it in 10% dosages, or even less, if you've been on it a long time, there's no reason you can't go really slow. If you've only been on it a few months, why taper over a year, right? Increases exposure. But compounding pharmacists, and they're all over town, they can make any dosage you want. So use a compounding pharmacist. Another strategy is a file and a jeweler's scale. So that people file off, the percentage that they want to cut, and then weigh it out. It's okay, we're down to 10% and 90% of that. And then for drugs that have beads, like Effexor has usually each capsule has around 250 little beads in them. I usually advise people to count the beads in their first pill before they start doing this. But pretty consistently, Effexor has around 250 beads in it, whether it's a larger dose or a smaller dose. But they count them, so see how many beads in it, and then go down by a percentage of beads. So if it's 250 beads, 10% might be 25 beads. Now, I know that they say that some of these beads are time release and some of them aren't, so that you're not guaranteed a smooth withdrawal that way. I have not found that to be my experience. I found that bead tapering is actually very effective and a good way to be able to cut it really fine. So I don't find that there's any supplements that help. SAMe doesn't help. Tryptophan doesn't help. Exercise does help. Eating right does help. And the other thing that helps is some kind of a spiritual belief, whether it's religious, whether it's meditation, whether it's yoga for some people, anything they find spiritual. So those are three things that go along with it. And the other thing, of course, a supportive therapist really helps. There's a problem with therapists because most of the time when a patient comes in and says, I'm tapering off this medicine, I don't like it, the therapist is using therapy to try to get them back on it. A lot of the therapists aren't taking these medicines and feel like, well, they're good for me, they should be good for you too. So finding a good therapist can be difficult, but you can have a supportive family. You should always tell your family or people you know when you're going off of these things. Occasionally, people have rapid onset of psychosis, and you got to tell your family and people who you live with you're going off of these things, because they may be the ones that can see if something drastic is happening. But you can have a supportive family, supportive therapist. Sometimes there's supportive psychiatrists out there, believe it or not. And increasingly, at patient request, psychiatrists are taking people off of the medicine. So those are the elements, I think. Then you got to have good genes. What I mean is you have to have the genetic makeup of somebody who's going to be able to get off of it. Some people just are not going to be able to.
It's too bad that you can't ascertain who those people are before their drugs are prescribed.
Yeah. Well, early on, I had to make a decision about research or clinical. I decided I was going to go clinical and be careful and be careful in my clinical observations. So I really haven't performed detailed studies. Like what percentage of the people are going to have persistent sexual side effects? I think it's much higher than they talk about. I will mention one study. This was a study done by a doctor who was trying to show that a switch to a different antidepressant was going to cure the sexual side effects. So people were on Paxil to begin with, which causes a lot of sexual side effects. He had another drug he was going to switch them to. So he had a group of people on Paxil, and he stopped the Paxil and put them on this other drug. And of the people who had sexual side effects in this study, half of them continued to have sexual side effects after 6 months, even though they were on this other drug. He was really upset because there's a psychologist, Audrey Barrick, out of Iowa City, who's really sharp about this as her field. And she contacted him. Oh, so you found half of your people had persistent sexual side effects lasting 6 months. He got kind of irritated. He never really, responded to that. And there were other doctors who were doing studies on sexual side effects. And none of them kept databases regarding how long they were off of them. But no, I have to say, my shortfalling is I'm not a researcher. I'm just a clinician. Although my observations are pretty good.
So Carol, who's watching live, says, I have no hope of getting off sertraline. I've tapered off several times and it did not go well. I'm 65 and I've been on antidepressants for 35 years. So is the longer a person's on, does that make it more difficult? And in a case like this, is there hope maybe even just to get to a lesser dose?
Well, yeah, I mean, a lesser dose is possible and desirable. It's harm reduction, if that can be done comfortably. But I want to address this issue. I mean, 30 years on an antidepressant. I know there are people coming off of them, but this is the group that seems to have the greatest difficulty. 65, it can take, if you go off of these and you have bad symptoms, it can be years of disabling discomfort. I mean, I'm into that age bracket. How many really good years are you going to have left? Is it worth it? Generally, I don't think so. And I want to mention something else. The clinician in me has observed that that is not widely known. This might help this woman too. The antidepressants wear off over time, or even cause depression over time. And early on in the game, you can switch one antidepressant for another. It's what they call cross tolerance, so that all the SSRIs are thought to be cross tolerant with each other. It may not be precisely true, but there aren't a lot of problems when you switch a person from one antidepressant to another early in their treatment. After, let's put this on.
Airplane.
Mr. Spam is calling me.
I was going to say, maybe it's people trying to get off their SSRIs. You better take that.
That's my private cell phone.
Oh.
You only get on, they want to call in the office. But what I was going to say is, as people are on these longer and longer, particularly 30 years on Zoloft, they're not cross-tolerant anymore. And I've seen people, older people, meaning people in their 60s have been on these 20 years or more, where the drug's not working so well, and they go to their doctor and they switch it for another drug. And what I'm seeing is that they're in a complete withdrawal syndrome. They're not having a relapse. They were better off until they tried to switch it. And then they're having, even though they're on another drug, supposed to be cross-tolerant to it, they have complete withdrawal syndromes. If the longer you go after stopping the drug without reinstating it, the harder it is and the less likely it is to work. But I've had some people where it's been tragic. For a couple of years, they try this one, try that one, try the other one, and you're staying in this withdrawal syndrome. So I think it's important to know when not to taper. And can you ask that woman, is she having a problem with her Zoloft? Can you talk back?
Is Zoloft and sertraline, that's the same thing?
Yeah.
Okay.
Is there a problem with it? I mean,
yeah, maybe she can comment. If you're still here, please comment in the chat. Dr. Shipko, do you think that psychiatric medication should only be prescribed by psychiatrists? Because I hear of so many people that go for a very short 5-minute appointment with either a nurse practitioner or a physician's assistant, and they'll say, how you doing? And maybe the person will say, oh, I have stress. And then that's what they want to do, is write a script for an antidepressant, as if it fixes everything.
You think psychiatrists are any different?
I don't know. Well, but at least they're supposedly trained better in this area, no?
Okay. There are no lab tests to make a diagnosis. There is no imaging or diagnostic studies you can use. Each guy is free to make whatever diagnosis he wants and however he wants it. And, using these genetic tests, that's just a way to make your patient think you know more than you do. And they might have some utility, but not much. What I find is because of this, each guy has his own special potions. Each guy has his own formulas, what he thinks works. And it's all over the place. They're supposedly trained better. But just because you say, oh, this affects this receptor or that receptor, you can't say, oh, I think you have an SA2 receptor deficit. So what happens is the elegance in training is all, oh, this drug affects this receptor and that one. And, they have different theories about how drugs might better work, but there's no lab tests, there's no diagnostic studies, there's no guidelines. Now, psychiatrists are highly variable. There are some, caring psychiatrists out there who give informed consent and talk to patients, take an hour for a visit. There's also psychiatrists that have you out of the door in 15 minutes. My favorite story from someone coming for a second opinion was she went into the psychiatrist's office and said, I'm feeling really lousy. He says, aha. And he wrote a script and handed it to her. And she said, what could he have possibly known? So I think the thing we need to do, let's have psychiatrists do the prescribing. But I want two things. I want a psychiatrist who's also trained in psychotherapy. Because if you've never had training in psychotherapy, as the current generation have not, they can't tell who would do better with therapy than medicines. And the second thing is, I'd like to see some sort of standardized informed consent required for each drug. I've seen places where they talk about prescribing being done by committee, not just a psychiatrist, but a group of other people looking at it. So I think it needs to be tuned up. These drugs are not nearly screened for effectiveness and proper use as much as they should be. You got a response from that woman?
I'm looking to see if she typed in the chat. And while I'm looking, I don't see her typing anything more. But, I don't know if you're familiar with Dr. Anna Lemke. She's a Stanford psychiatrist who wrote Dopamine Nation. And I interviewed her, and she was saying at one point she was given the opportunity to go on these drugs and she turned them down because she felt like they were trying to medicate her personality.
No, that's what they do. What Dopamine Nation? So is she like big on the idea that we're all responding to dopamine?
Yeah, like it's a really, really interesting book actually, and about patients she worked with that were addicted to different things like sex and things like that. And it was romance novels. I thought it was a really wonderful book. Okay, Carol so has responded. She said, I just feel some shame with taking these medications. I feel the best I ever had since quitting sugar and going vegan. I thought I was well enough to get off the antidepressant. I guess the Zoloft helped.
Well, if that's the case, what is her name again? Who are we talking to? Carol. If that's the case, I don't think it's worth it for you to try to go off these drugs, the Zoloft. I mean,
she says it helps somewhat. She's saying it helps somewhat.
Even if it's not helping at all, the risk of going off after 30 years, the risk of developing akathisia is really high. And if that happens, it's miserable. If you're feeling okay, you're 65, I would take my chances continuing the Zoloft rather than trying to go off of it. I will say the other thing to add on to my comment before. If you feel like you're getting more depressed and there's a problem, don't switch from Zoloft to a new drug. Keep taking the Zoloft and add something else on top of it if you have to. Because I'm just finding that cross tolerance is not there in people who've taken these drugs for, I've seen problems at 10 years, but 20 and 30 years for sure. So, and there should be no shame about taking it. I mean, just because, nobody told you you would have trouble going off of it. I think you can just take it and understand that it's probably your best option for now.
Great. I've heard from some people that getting off benzodiazepines is equally hard.
Well, I think some people may say that. I haven't found that to be the case. Now, in my work with benzodiazepines, most of the people I've taken off of benzodiazepines have not also been on SSRIs. And one theory I have is that they're having chronic problems from the SSRIs that they're on. And when you try to you remove the benzo and you're seeing those problems emerge. I just haven't had as much problems. I will say one thing about benzodiazepines, Klonopin is surprisingly difficult to get people off of. I had a couple of people who couldn't stop taking Klonopin. Klonopin is the one they tell you is less addicting. So that hasn't been my experience. But I mean, I've read about it. I haven't had that in my practice. Like again, in my practice, my patients are mostly just been on a benzodiazepine. But I don't think they are as hard to get off of as SSRIs. Or it could be variable. For one person, it's one, and one, it's the other.
Thank you. What are your thoughts about Lexapro, asks Chris.
What am I supposed to think about Lexapro?
I don't know. Are you for it?
I'm not for or against anything. It's one of the antidepressants, one of the SSRI antidepressants. Helps some people, doesn't help other people. But I don't have any opinion on what's the great antidepressant that should be used or not. I feel they're all really similar. I favor using drugs that have been around a long time because we know more about them. But otherwise, and I guess the other thing I'd say, Paxil and Effexor are the two drugs. Paxil has the most side effects. That's been established. It's also difficult to stop. And Effexor is very difficult to stop. So those are two I don't like. Otherwise, they're all about the same to me.
Well, the people that are being helped, what does that look like? Because so many of the people I know that get on them, they have no affect anymore. It's like they're not depressed, but they're not happy either. They're just kind of flat.
Well, then are they really helped? I mean, I think Whitaker talked about this a little bit too. Some people are anguished because of the intensity of their emotions coming from childhood abuse in ways that are unimaginable. And you take those powerful, awful affects down, and you got a pretty normal, nice looking person, But these people who become flat, I don't find them to be particularly pleased with the drug's effects. Those are people who are having side effects and don't like it. Right. But
yeah, makes sense. I always say if you're happy on it, but yet it just seems like so many people do want to get off them and struggle with that, which is where you come in. Is there any literature anywhere on how to safely stop an SSRI?
Well, there's really good information on tapering available through a website, Surviving Antidepressants. Although I don't advise throwing your case out to the group and asking everybody what you should do. But they have the best information on tapering. I think that the people who did the tapering strips have some literature. But in terms of a single place you go, how to go off that's comprehensive and three-dimensional, I don't really know if it might be out there. You know what I mean? I don't know all the information and stuff.
Do you think the microbiome plays any role in things like depression or anxiety?
Oh, I'd like to know. It must, right?
I mean, that's what I hear from some people.
Well, the microbiome, we don't know much about it, but it affects everything. Aren't there more bacteria in your gut than cells in your body?
Supposedly, yeah. Isn't that crazy?
That's pretty powerful, you know, and the gut and the brain are very intimately connected.
Two-way bi-directional highway. That's what I'm understanding from some of the guests I interview. So Meg says, I was prescribed trazodone to help me sleep. I'm worried about side effects and addiction. Is that a drug of abuse for some people?
Not a drug of abuse. Trazodone is known to affect serotonin, but it's not an SSRI. Any psychiatrically active drug can be one that you are potentially unable to stop, but that's not known to be that bad. I don't hear much about trazodone and people wanting to come off of trazodone. It seems like something people can stop.
Nice. Yeah, I'm interested, if you don't mind, about the book you wrote on panic disorder, because right before we logged on, you said you feel as if you wouldn't change anything if you wrote it today, and it's still relevant today, because a lot of people that are watching that I know suffer with panic attacks.
Well, what can I say about it? It was, I had a website in the 90s that was the most comprehensive information on panic disorder. I had articles on all kinds of aspects of panic disorder, a message board, and I did research on panic disorder and its relationship to the gut. On my website, stuartshipko.com, under research, you can click on it and you will see a schematic summarizing the research I did on that. But I didn't use the research. What I mostly did was wrote about aspects of panic disorder that most people wanted to know about. And since I had this website and people were posting on my message board, I saved lots of messages that were the most interesting and meaningful. And I wrote about the things that most people were contacting me about. So it has a lot of information. I also, I wrote back then that I think the best excuse me, medical treatment was a short-term course of benzodiazepines, short enough to knock out the panic attacks, usually under 2 weeks, and then switching to as needed, meaning almost never. And I argued against taking SSRIs on the basis of hard to get off, more side effects, and the persistent sexual side effects.
Thank you. Mona says you mentioned B complex vitamin, a particular one that you recommend.
No, I mean, B complex comes in B50 and B100, and anything off the drugstore shelf that says B50 or B100 will do the job.
Is it true that if somebody is on an SSRI, they should not drink alcohol?
Ah, that's a great question. I'll tell you why. Alcohol, okay, you're not supposed to drink with any of the drugs, fine. This is to be a flat don't. But alcohol and certain antidepressants have a weird effect where alcohol is better than it's ever been. There was an article in Slate, I don't know, it must have been written 15 years ago by a reporter called, I think it was called Shy Like Me. But this guy wanted to see what Paxil would do for his social anxiety disorder. And he discovered that when he drank on it, nah, he wasn't doing anything, but when he drank, he says, yeah, this is it. So there's a lot of people who find the combination of alcohol and an SSRI to be enormously pleasing. In fact, scary pleasing. But in terms of, can you take a glass of wine, a single glass of wine at night with it, or maybe 2, but not more? I think most doctors say that that's okay. My personal opinion is that it's never really okay to drink when you're taking psychiatric drugs.
Thank you. Thank you. I appreciate you saying that. Are you familiar with the work of Thomas Saz?
Oh, yeah.
What do you think about him? He can't be on the show, unfortunately. passed away, but I found his work interesting.
I think he's great. I mean, he said a lot of things over the years. He got discredited for his association with the Scientologists. Yeah, I mean, I've been associated with them at times for different things. The enemy of your enemy is your friend. But Thomas says, I think his central point was that there's no such thing as mental illness, right?
Yeah, The Myth of Mental Illness was his book.
Well, since there's never been any biological cause for a mental illness, or if they do find it, it becomes a physical illness. I think these are just uncosmetic stress responses. I think we were built into the system that it's a shame that some people become out of touch with reality and delusional, or they become manic to a degree that they ruin their life. So it's hard to say there aren't things that are really wrong, but I can't find these without a pathology. I don't think they're diseases. And then what we call depression may not be. Like, I had a gentleman from the Middle East who he wanted me to give him some pills to take back to his mother in Iran. And he said she was so depressed, you suggest something for her. And what I found out was that the woman lived for her family. She lived to cook and clean for the family and take care of her husband. Her kids were all gone. Her husband died. She didn't know how to read. There wasn't any real functioning television. This was a couple decades ago. I said to her, if I was going to take care of your mother's depression, I would teach her to read. He felt like that was the silliest idea that I could have given him. And that, of course, she had a disease. So we may be seeing these as diseases from a cultural perspective, from a societal perspective, but I don't think we're talking about disease in the same way as a medical illness. You got something there? You're typing on it?
Oh, yeah. I was just a comment in the chat that I was typing to one of the viewers. Oh. What about in children, though, as the SSRI use in children? Because, I mean, our brains aren't even fully developed when we're children.
Oh, I can be unequivocal. There has never been any literature that shows safety and efficacy of those drugs in children. It is one of the great crimes in psychiatry. In fact, there's a nice article on Mad in America going through that. But I've long known that. And then there were studies done, shameful studies, trying to prove efficacy. They conclude it was effective when the study itself says it wasn't. But no, there's no place for those drugs in children.
Where do you think all this is going? Are they going to keep to try to develop new and better drugs? Are we going to wake up one day, realize this wasn't the panacea that some people thought it was?
No. The pharma people win. There will be increasing numbers of people who recognize that there are side effects and problems. There are increasing numbers of people who say, oh, I won't take them, who may or may not have good information. But we, as Whitaker was talking about this, we trust the pharmaceutical industry. And if they say they have a pill for a problem, most people are going to trust it. And they do keep coming out with new drugs. And the new generation of psychiatrists are so steeped in the drug concept. So I have to say that what's going to happen is a polarization, maybe like the rest of our country and everything. But you'll see some people, increasing numbers of people are not taking these drugs. They just refuse.
No matter how many drugs they develop, they haven't seemed to find one for helping somebody not be an asshole.
Now.
I'm just kidding. But this is really, really so interesting. And I appreciate the work you're doing, especially because it's not what everybody else is doing in your field. It's kind of reminding me of some of the doctors that I interview in the plant-based space that go against, not really going against, because I feel like what they're teaching is correct, but not doing what everybody else is doing.
Well, you're welcome. Consumer demand is shaping doctors. More consumers, just like Carol, people want to go off these drugs. So I think that doctors may develop a knowledge of how to go off these drugs or side effects as time goes on.
Yeah. I find it so interesting when you see commercials for psych meds or any meds, and then the patient goes to the doctor asking for what they saw on television. And I love when they say, if this psych med isn't working, well, you need this one.
Are there commercials saying that?
Absolutely. I can't remember, maybe it was like, if you have this and it's not working, take Abilify.
Oh, it must be the Abilify commercial. It's an add-on.
Yeah. So this drug doesn't work, so let's give you this one in addition.
And when they go to their doctor and ask for it, they get it.
Yeah. Well, what can you do? So are you taking new patients if somebody wanted to work with you?
Most of what I'm doing is just giving consultative opinions. I'm not personally supervising people going off the drugs just at this time. I might do that again in the future, but there's no need to. I can give them the knowledge they need to work with their existing doctors. And are
you still writing for Mad in America? And maybe tell the viewers what that is. That's a wonderful blog.
Well, Mad in America is a website. It's more than a blog. It's a website, and it's probably the repository of the best thinking in psychiatry today. Robert Whitaker, who we talk about, who is a fabulous champion of science and the scientific information behind these drugs, wrote a fabulous book called Anatomy of an Epidemic, which 10 years ago is as relevant as it was then. Excellent, excellent book. And then he started this website. Mad in America is actually the name of a book he wrote earlier. And people blog, doctors write there, patients, some people what they call psychiatric survivors. They review scientific articles. It's a fabulous website. It has a really good information on lots of different subjects related to psychiatry. I do blog there. I haven't written one for a couple of years, but you can see some of my opinions on antidepressants in the blog site on Mad in America. But that's an excellent place to go for information.
I found that story you said about the actor, how when he was busy, like he didn't notice that he was off the drugs so much.
Yeah, I find that interesting too.
Because I think a lot of times, like, people are medicating their life instead of their illness.
Well, this guy wasn't medicating his life.
Well, meaning like, I guess maybe I didn't phrase that right. In other words, that people had more meaningful things in their life. They, like when you're busy, you don't always have time for things like that.
I have no idea what went on and what this means. I am astounded. We went really slow, and it was so difficult for him, and it was so uncomfortable. The idea that he could stop all at once and never look back, I'm not sure. I mean, it does argue he was working 17 hours a day. It does argue that there might be something about being really busy, but what would that be?
I don't know. I don't know. What can I say? Well, good for him, though. Hopefully he's doing well off the medication, and hopefully that people that are on them, if they want to get off, will make attempts. And if they can't, not feel so bad about it, because
that's important. I'd rather see somebody stay on the drug than become disabled, lose their relationships and their job. And I think there is something to what Carol was saying about shaming people who are on the drugs, and that's to be avoided too.
Well, I wonder who's shaming her, because it couldn't be the people that put her on them, I would imagine. So it must be people that are thinking you shouldn't be taking those drugs.
She probably went on a website.
Yeah. It's interesting though, when, like if you're on, say, levothyroxine for hypothyroidism, you can get health insurance, but when you're on psych meds, they can exclude you just from that.
Yeah, I heard that.
It's absolutely true. And make it really difficult for people, especially if they're on one that is not, yet on, still on patent, because how some of them are really expensive until the patent runs out.
Well, so the insurance companies know something.
Yeah, pre-existing yeah, I mean, so it's.
Oh, but they don't insure you because they think you're going to die early, right? You're talking about life insurance.
No, I'm talking about health insurance, that people trying to get health insurance that are on certain psych meds, they use that as pre-existing condition and they won't insure them.
Well, with Obamacare, you can't refuse insurance.
I'm talking private. That's different. Like when you work for a company and you're in a group, but like when people are some people that are self-employed trying to get private insurance. Carol says she shames herself. Well,
no,
stop.
okay. Yeah, stop it.
Have you ever seen the Bob Newhart thing? Stop it. The famous
No,
Bob. I'll
it?
have to send that to you. But Carol, stop that. It's hilarious. And by the way, thank you, Carol and Angela, for your super chat donations. Well, this is really a fascinating discussion, and I really appreciated what you had to say about it. And I find that more people are wanting to know this information, because a lot of them don't know that once they get on, they may not be able to get off, or at least not get off easily. And like you say, they should at least tell the person. Right?
I agree.
It should be all medicines, not just psych medicines. They should tell you at the beginning.
That's so true.
Absolutely. Well, thank you so much, Dr. Shipko. It was a pleasure meeting you.
And it's been a pleasure meeting you, and be well. And if you have any questions, let me know. All
right. Thank you. And thanks all of you for watching another episode of Chef AJ Live. Please come back tomorrow when my guest is author of By Any Greens Necessary,